and algorithms. So thank you. You made it.
Yes. So it's happy to be here, and good afternoon, everyone. I'm Handa from Taiwan. So it's happy to follow the previous question and discussions on the diagnosis and the reliability of using the prediction models and the algorithms to diagnose a small choroidal melanocytic lesion. So first, I'd like to start with some myths and facts. So once you discover a pigmented mass in the choroid, first question, the diagnosis of a choroidal melanoma without needing a biopsy is 99.5% correct. Myth or fact? So according to the collaborative ocular melanoma study, this is a fact. Second question, your diagnosis, that is meaning everyone here in the room, of a small melanoma is half the time correct. Myth or fact?
Fact.
This is also a fact because any small pigmented lesion in the choroid is either a melanoma or a nevus. So even if you were to guess, it is still half the time correct. So last question, Professor Xin here, his diagnosis of a small choroidal melanoma is still half the time correct. So Professor Xin is our chair and with 20 years of ocular oncology experience, but unfortunately, this might still be a fact. So we'll talk about the details shortly later. So go back to the first question. So according to the COMB study, which is a prospective study, which compared medium and large choroidal melanomas treated by either enucleation or another treatment, the pathology confirmed the clinical diagnosis in almost 100% of the eyes. So this has given the ocular oncologists a lot of confidence in using clinical diagnosis for melanomas. However, you'll definitely ask, how about the small melanomas? So the small melanomas were included in the COMB study. The diagnosis criteria were clinical diagnosed by an ocular oncologist and a thickness within 1 to 3 millimeters. And these small tumors were not treated but only observed unless it grows. So what was the outcome? So it was predicted after 5 years, only 31% of these lesions will grow. What does it tell us? So these group of so-called small melanomas, after 5 years, only 30% show growth and were likely to be melanoma, whereas the other 70% without growth in 5 years were likely to be a benign nevus. So this has prompted the ocular oncologists to find more clinical features to see if we could differentiate the small melanomas versus nevus. So most of you are aware of the TFSOM prediction model. The latest version is to find small ocular melanomas doing imaging, which has 6 features. And the aim of this model was not to diagnose melanoma at the first presentation, but to predict tumor growth in the future. Let's take a look at the performance. So a nevus with no risk features, the 5-year malignant transformation is roughly around 1%. And if you have additional risk features, these risks rises to 11% and so on with more risk features. So this looks quite good. However, if you look closely, even with 4 or 5 risk features, the prediction is roughly around half of the patient. So any ocular oncologist or even Professor Xin here uses this prediction model to predict tumor growth or to diagnose a small choroidal melanoma at the first presentation, they are likely to be wrong in half of the cases. Furthermore, if you look at the range of prediction, it has a wide variability with different combination of specific risk features. For example, if you compare one lesion with 1 risk feature of orange pigment and another lesion with 5 risk features of TFOMD, you'll find actually the lesion with 1 risk feature has a higher prediction of growth compared another lesion with 5 features. So this is rather bizarre. We need to be aware that using only the number of risk features is very risky. Another example, These patients presented in 2022 with a small lesion and 2 risk features. According to TFSOM, the prediction of growth in 5 years is 64%. Ocular oncologists offered a diagnosis of a small choroidal melanoma and offered treatment. So more information, low metastatic risk and high risk of visual impact. Will you still treat this patient? So the patient opt to observe first, and 2 years down the line, you can see that tumor remained to be exactly the same and that it was finally diagnosed as a leaky nevus. So back to 2022, were you still willing to call it a small melanoma, or were you diagnosed it as a nevus? The answer is no one knows. So probably there's a third diagnosis, which was mentioned earlier, an indeterminate melanocytic tumor, which we basically accept that we don't know the answer and we discuss the management with the patient based on this. So next, I'd like to introduce the MOSE model, which was proposed by Professor D'Amato in 2021. It is very similar to the TFSOM, but with 2 new features, the mushroom shape and enlargement. Also, this model has an unsure category and without needing the ultrasound. So it makes it simpler for the general ophthalmologist to pick up and use. And depending on the total score, a different management of various interval of review or an urgent referral to ocular oncologist is suggested. So comparing the 2 systems, the MOSE is more suitable for non-experts, while the TFSOM is more for ocular oncologists to estimate the risk and to guide the treatment, but none of them were designed for the diagnosis of a small choroidal melanoma at the first presentation. So lastly, I'd like to talk about the AI models. So a lot of papers have been published regarding differentiating melanoma versus NEVA using AI prediction, but only 2 of them focus on small lesions. The first are proposed by Professor Singh, and he mentioned it a little bit earlier. They are looking to the small pigmented lesion in the choroid with a thickness ranging from 1 to 2.5 millimeters in thickness and has a very solid diagnostic criteria where the nevus was confirmed to be stable for at least 2 years and the choroidal melanoma confirmed with growth or pathology. They have a very high AUC, but the limitation is the case number. A recent publication from the Wills and the Mayo Group, they have almost 3,000 lesions, and they try to use AI to predict nevus transformation. They have a good AUC, but the nevus, not all of them were confirmed with follow-up visit. So despite these shortcomings, in the near future, we're likely to see that AI models can help to elevate the accuracy of doing a prediction, or even we can provide an early diagnosis, but we need more data and validations on this. So in conclusion, the diagnosis of a small choroidal melanoma upon the first presentation is debatable. The risk features predicting growth is well established. However, the prediction of future growth does not equal to a diagnosis. We should consider using indeterminate tumor instead of a melanoma for the lesion with risk features, and AI is likely to come into the picture very soon. So lastly, probably the most important message of this talk is that although we are not 100% sure about the diagnosis of a small lesion, we are 100% sure that some of these lesions is melanoma. So we need to have a regular follow-up and review for these patients. So that's the end of my talk. Thank you so much, and looking forward for your questions and comments. Thank you.
Any questions from the audience? So I want to add one more confusion to this confused topic. So that when you're looking at these risk factors for growth, and I want to come back to this again, it's talking about 2 things. One